Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. It's estimated that 72% of children will have a heart murmur at some point during childhood or adolescence. It's also the most common reason for a referral to a pediatric cardiologist. But the majority of murmurs are innocent or benign, meaning they don't indicate any underlying heart problems. So how do you know if your child has a heart murmur? And when should you be concerned? And what is that noise anyway? Today, we'll answer those questions and more as we're talking with Dr. Jai Udassi, Director of WVU Medicine Children's Heart Center. Welcome, Dr. Udassi, to Live Healthy West Virginia.
Well, thank you. Thank you so much for having me here. My relationship with camera is pretty old. I used to be on a TV when I was 17.
Okay.
Too long ago.
All right.
But I'm excited to be here. Thank you so much.
Fun fact, we were discussing this. You used to be on soap operas a long time ago.
Don't ask me video copies for that.
Okay. Maybe next time.
Yeah.
Okay, let's start with the basics. What exactly is a heart murmur?
Yeah, heart murmur is basically when you put a stethoscope on a chest, you can hear this extra whispering, gurgling, machinery type noise, which can be, as you said, benign or pathologic. So when a pediatrician is usually the first one to hear, and then they assess it by degree of the noise as far as grading we take. So typically grade 1 to grade 6 textbook explains.
Okay.
And then the type of noise and also what phase of the heart sounds it's coming.
Oh.
It can be coming early in the systolic phase of the heart when it's contracting.
That's contracting.
Contracting, or it can be in the filling phase of the heart where the heart is just filling. It's called diastolic phase.
Okay.
So pediatrician hears it, depends on is the judgment of the pediatrician or any other provider, I should say, nurse practitioner or family practitioner or any other specialty who's seeing the patient for any reason. They can hear the noise and then definitely then refer to us for further evaluation.
Okay. Is this a fairly common thing?
Yes, as you said, this can happen in up to 2/3 of children of any age. Most babies have some kind of murmur because their extra vessels open, which is supposed to close by second day, third day of life.
Oh.
At birth, PDA is the common vasculature structure which is needed when baby is inside the mom's uterus and being developed. After delivery and baby's outside, doesn't need the PDA. It closes in 2 days and murmur goes away. So having a murmur at birth is quite common.
What's that PDA stand for?
Patent ductus arteriosus.
So it's like another vessel that's open?
It's a vessel which is required during your development part of the heart where blood is diverted because lungs are not being utilized. As you know, baby's not breathing inside, so blood doesn't need to go to the lungs. So that vessel diverts the blood from lungs to the aorta, which is systemic circulation.
Okay.
And later on when you're born, you don't need it.
You don't need it.
Now you need a blood into the lungs, so the PDA itself closes over first 24 to 48 hours, sometimes third, fourth day, but classically first 48 hours. So murmurs are common at birth and then less and less later in the life. Then there are some murmurs who appear in childhood, like school age.
Sure.
Those are mostly benign murmurs which appear later on. The pathologic murmur typically is there from birth continuing, except some valve disease problems can happen later on and give you murmur.
Okay, so what's the difference between a benign murmur and a pathologic murmur?
So it's a nature of the sound.
Okay.
If it's grade 1 to 2, could be benign, soft, systolic murmur. So I say as a rule, murmur which is grade 3 needs to be looked at. Now imagine grading is also very subjective phenomenon. You have to listen, and then if you have a good hearing, you can call grade 2, grade 3. So that's why now there's electronic stethoscopes. So the sound can be modified right? You can increase the volume and you're going to hear better,
Okay.
right? So the grading is kind of based on a classic original teaching of common stethoscope. Can you easily hear it? So I say medical students cannot hear grade 1, generally speaking, but they don't have experience.
Right, right.
If they can hear, it's already grade 2 in my view. And we can hear grade 1, grade 2. But again, subjectively grade 3, if you're calling it, then it could be looked into a pathology. The other most important part, if you hear a murmur in diastolic phase of the heart, filling phase of the heart, that almost always needs to be looked further.
Okay.
And will be chances of abnormality.
Okay.
So the pediatrician really, or provider, focuses on that sound, what phase it's coming. So grade 3, any murmur grade 1, 2, 3, or 4, or 5, or 6 in diastolic phase, or having a very loud murmur as such machinery type, continuous murmur. PDA murmur, classically we call it machinery murmur. It's during diastole and systole, means filling heart and contracting heart, noise is there.
It's a lot of noise going on.
It's a noise which is on both phases, so like continuous.
Oh,
so
okay.
that murmur is a duct murmur, which they refer us very quickly early on.
So that should be paid attention to.
Paid attention to.
Yeah.
But generally speaking, most murmurs are benign. So if your child has been growing well, if your child is thriving, feeding, pediatrician tells you murmur, there's no reason to get alarmed or worried a lot. Because chances,
if it's benign,
if it's even if it's pathologic, let's say, it's not going to change on you in next day or 2 or 3, because if the baby's doing well.
Right.
So and then we figure out, okay, classically there's a small hole in the heart maybe causing this, or this PDA is there causing, or some other extra vessel causing, or valve, which are the structures, are the doorways to the heart for the blood to come in and out. They could be abnormally opening or closing. They can cause. But what I'm trying to say to the parents here that if everything is going well with the baby, and pediatrician tells you murmur, and they call us, and we try to see babies same day, to be honest. I can announce my cell phone right now, and people can just call me. We'll see them in the clinic same day. We have a very good, robust referral system, and then seeing them right away. But if it takes a day or 2 or 3, what I'm requesting parents not to sit at home and worry too much about it, because baby's doing well. If it's benign, great. If it's some pathology, it is probably fixable and dealable, and gives you time before it becomes too much of a problem.
Okay. If it's benign, do you usually grow out of it? Because I think when I was little, this was a long time ago, I remember them saying, I had a heart murmur, and then they're like, you'll grow out of it.
Yes.
And I think I did. I haven't heard anything about it since.
I can give you a free consult now. So most benign murmurs, because they're coming from normal flow of the heart. And what happens is most benign murmurs do get a little bit louder when you are sick otherwise, because blood flow is augmented.
Okay.
So classically, it's heard by pediatricians when baby has a URI or cold symptoms, cough, fever, congestion. They're going for a visit, and then all of a sudden, pediatrician didn't hear the murmur before, normal visits, well child care visits, and now he can hear the sound, which is more prominent because of sickness, because blood volume is now more, and those kids are kind of in a hypermetabolic state, we call it, where body requiring more cardiac output, heart rate is a bit fast, and so you hear those times.
Right.
But most benign murmurs will disappear, will go away with time. So classic age is like the most common benign murmur is called Still's murmur. Still's murmur, STILL apostrophe S, that Dr. Still described way back then, and was a physiologic murmur, comes from the dynamic movement of the blood, and some babies have, some don't, right? And typically school age means 5 years, 4 years. It's a soft sound, systolic sound. We call it a musical sound. It's like comes in one phase of the heart and disappears after months or year, or you may not hear once baby is well back to normal health and no cold, disappears.
So what are the causes then of a heart murmur? It sounds like, it could be something as, I don't know if that's serious, but it sounds serious to me when you said a hole in the heart, but it could also be caused by other things.
Yeah, so classically, once we say that there's a pathology causing it, classic, it's the small hole, either in the upper two chambers of heart or lower two chambers of heart. As we know, heart has a 4 chambers.
Yeah.
2 on the top is called atria, or atrium being 1 and atria being 2, right and left. And lower 2 chambers are called ventricles, left ventricle, right ventricle. There's a wall in between them, and blood shouldn't be moving through the wall. So sometimes there's a tiny hole or small hole or large hole, upper or lower chamber. The upper chamber hole classically is tolerated better and we give time. The lower chamber hole, depending on the size of the hole, it can cause a little bit of congestion, because what happens is that the blood moves more blood goes to the lungs than the body, so that they feel more congested in the lungs.
So does the hole sometimes close on its own, but sometimes need surgery?
Yes. So most small holes can close on their own, both chambers, upper and lower. Some larger holes, and depending on the location of the hole in the lower chamber, may not close.
Okay.
Most holes, depending on a medium size, have a 50-50 chance, I say. We buy time, because more time you can give for spontaneous closure, better it is.
Oh, okay.
And we determine that by depending how large is the hole, how much blood is shunting from one chamber to other chamber, and how much is that affecting baby's lungs itself and heart indirectly, in the sense that heart has to work harder to pump, and the chamber gets a little dilated because blood is coming back, which is due into the lungs. So I think the factors we watch, but we buy time as much we can. We can use some medications depending on the size of the hole.
Okay.
And if you can, in my view, key is baby breathing okay, feeding okay, gaining weight. 3 major factors.
Sure.
Medications on board, you can wait as long as you want.
Oh, wow.
As far as baby's doing all those 3 things and heart is not getting dilated as well, or there's no other factors affecting. There are some other factors depending on the area of the hole. It can cause effects on the valves,
Okay.
especially aortic valve can leak, and those factors will push us to do surgery early.
Surgery sooner. Okay. So it's obviously a case-by-case
Case by case.
Case-by-case. How common are the pathologic murmurs?
So the
And are they usually a big deal? Like, oh, we got to do this now.
Yeah, depends how knowledgeable and thinking-wise you are, depending. If you hear a heart problem, like everybody gets scared.
Yeah.
I can tell you the congenital heart disease, which is including the holes in the heart and then the major lesions, roughly it's a 1% altogether.
That doesn't sound like a lot.
1%?
1%?
1% means every 1 baby out of 100 deliveries. That means 10 babies out of 1,000. And you know, in the West Virginia whole system, we are doing 20,000 deliveries.
Oh, wow.
So you're looking at 200 babies.
Yeah.
And then certainly that's only the congenital heart disease part. We didn't talk about rhythm problems. We didn't talk about any other acquired diseases. These are congenital, means at birth you have.
Okay. Okay.
Thank God, out of those 1%, the major problems where you required surgery first few days of life and then few months of life are even less.
Okay.
Right? The
Right.
major lesions are less.
Yes.
So, but it's a lifelong in the sense that you repair and you watch and you watch and you watch and you just fine tune the things. But generally speaking, we say that it's 10 per 1,000, 8 to 10 per 1,000 deliveries.
Okay. Could a child have a heart murmur but not have symptoms?
Absolutely. You can have a heart murmur, benign type will have no symptoms. That's a normal.
Okay.
If it's pathologically, depending on the size of the hole or size of the problem, if it's a collateral vessel, if it's a small duct or large duct, may not have symptoms at all. In fact,
How do you diagnose that then?
with ultrasound,
Okay.
echocardiograph,
Okay.
which gives you a beautiful pictures, and sometimes we do a CT scan of the heart as well, but mostly we do ultrasound, which is called echocardiograph, gives you amazing nowadays technologies advanced, and we have 2D pictures with a color, and we can see the blood flow
Sure.
directions and everything. So it's diagnosed that way. The key is that when I see a baby with a hole in the heart, I don't want baby to get symptoms. That's the whole goal.
Right.
Because symptoms mean the baby is going to be now using more calories and not gain weight, because heart will be beating fast, lungs will be breathing fast. They utilize a lot of calories in that. We call it extra calorie consumption, and they don't gain weight, no matter how much they eat. So that's the indication that we got to do something.
Yeah. Okay. I know some questions some parents may ask is, can your child have a heart murmur and grow up healthy?
Yes, absolutely. Needless to say, benign murmurs, yes, of course, will be normal. But if you have a small hole which gets spontaneously closed, murmur is gone, hole is gone, you're growing normal. Most babies, we do surgeries for those holes are growing normal, have a normal lifespan and normal life.
Yeah.
I always say they can go and become whatever they want to be honest. Very complex lesions, of course, could be some limitations depending on how bad the lesions are. But these common murmurs, the common holes, outcomes are very good nowadays.
So even if you have a problematic murmur, that doesn't mean, I've got to limit my child's physical activity or something.
No. I think that depends on the multiple factors. So you have to assess and discuss. Most children with a heart problem, if the function and squeeze is normal, we don't limit them.
Okay.
We don't limit them, and we should not limit them, because I can tell you that we are now causing more sedentary lifestyle, not other muscle strength buildup.
Right.
So we need to continue healthy lifestyle, continue healthy diet, exercise, do all the things. Now, some lesions you don't want to have them do heavy lifting or do a competitive sports. Some of the lesions where the function is problem. Otherwise, they should have a normal, healthy lifestyle, continue their physical activity, do not restrict them, do not restrain them from doing any. Yeah, of course, you don't want to do a lot of wrestling type and jump up and down. But at the end of the day, healthy, people say, just sit down, watch TV all day, and I'm not going to walk around because I have a heart problem. No, that's not right.
Okay.
You got to continue a healthy lifestyle.
Common sense, right?
Yes.
So how do you treat heart murmurs?
I think heart murmurs will be treated based on the cause of their heart murmur.
That's what you're really treating.
That's right, because what's causing the noise? As we say, it's benign, do nothing anyway, heart is normal. It's abnormal, if it's extra vessel, you go close it, especially PDA. There are devices we can go as young as 800-gram baby.
Oh my gosh,
you can
really?
go with a catheter and block that. And murmur goes away, the PDA goes away, and baby starts gaining weight.
Wow.
We have two interventional cardiologists.
That's really minimally
invasive. Yes, absolutely. We've done many here the last few years, many. And then other causes will be, of course, hole in the heart. You have to do surgery sometime. Sometime you watch it and murmur, let it be there, because murmur is not hurting you. What's hurting is the cause of the murmur.
Right.
And once you determine that and you manage it, then murmur becomes secondary.
Are there any complications from heart murmurs?
Generally, again, depends on a cause as well. What's causing the murmur? So if you have determined those reasons, then how bad those reasons are, or etiology we call in our language, cause for the murmur, then complications will be all based on that, or prognosis will be based on that.
Can they be hereditary?
Again, most heart diseases, we believe, heart conditions in the babies, congenital heart defects, have some component of genetic, but till today, we have not determined a single gene causing X lesion or X defect.
Okay.
We call congenital heart disease the multifactorial, where there's some component of the genetics, component of the external environment, and some during the development phase, some factors happen which cause it. There's nothing that parents are doing wrong that we can pinpoint, nothing that they carried in the genes of the family which is pinpointing, nothing that they've done or taken extra. Now, there are some associations. Mm-hmm. There's a cause and effect, and then there's association.
Sure.
Associations are that we don't want smoking can cause heart defects during pregnancy. Alcohol use, excessive alcohol use can cause heart defects. Mm-hmm. There are some syndromes where you have associations, again, like Down syndrome has a 40% children can have a heart defect in murmurs.
Okay.
So I think it's all multifactorial and some associations. Nothing that we can say to mother or father, that this cause this defect, hence the murmur.
Gotcha.
It has not been known. I've done a lot of genetic work in my career in the past as well, and nothing has been. Now, it will one day, we'll know. I believe everything is genetic based, the way I'm talking even,
Yeah.
or holding my hands even. It is genetic based, but today's date, knowledge is not common yet.
Okay. Good to know. When should my child see a pediatric cardiologist?
I think there's no routine need of seeing pediatric cardiologist.
Okay.
Pediatrician is your gatekeeper.
Mm-hmm.
Of course, from delivery room. Of course, now, when baby is being developed inside mother, nowadays there are ultrasounds where OB team will do a screening ultrasound. If they suspect heart problem, heart structure, most OBs are very capable, and they will then refer to our fetal pediatric cardiologist. We have 3 of them, and we're hiring 4th one soon. So then they will do a formal, when baby is inside the mother, a fetal echocardiograph to determine the defect, and we start teaching and planning from 20 weeks of gestation, and then after delivery care happens right away here, of course.
Okay.
So then you're already seeing a cardiologist. But if baby is normal pregnancy, OB said ultrasound is normal, baby's delivered in normal, hospital with a normal nursery, there's nothing at birth. We do nowadays, you must have heard the oxygen pulse ox test, where
Yes.
if the pulse ox is low, then you get a screening. That's a screening test. Or if you hear a murmur early on, which is persistent after day 2, 3, then you see cardiologist. Or rhythm, if you're seeing on a monitor some changes. Otherwise, there's no routine need of seeing a cardiologist.
Okay.
Now, I do believe, now my colleagues may not agree with me, that I think every person should have an echo in lifetime, 1 echo, so that you can you know your structure's normal.
Yeah.
It's a non-invasive test. Of course, takes a lot of resource, but that's the vision I have, that at birth you do a 3 or 4 views of
Like a baseline.
like a baseline. Look at the heart quickly. Now, it's far from happening because it requires a lot of
You can
resources.
dream.
We can dream. We can dream. Then you'll pick up early.
Yes. Yes. So why don't you talk a little bit about the level of expertise of the team at the WVU Medicine Children's Heart Center? I mean, we've got some heavy hitters over there, don't we?
Yes, we're very lucky here. I must say that program in a way was revamped middle of 2021 when I arrived with Dr. Christopher Massio, who's our chief of cardiac surgery. We started revamping the program since then, and we have hired multiple faculty at every level, including second cardiac surgeon, Dr. Chauhan, Dhawal Chauhan, cardiac anesthesia, pediatric cardiac anesthesia team. Coming to cardiology, we have now 2 cath doctors, interventional cardiologists.
Okay.
We have electrophysiology covered with Dr. John Flips covering us. We have multiple imaging doctors, cardiologists with us, multiple fetal expertise cardiologists with us. We have a full-blown imaging service, the CT MRI, with now 3 of them. 3rd doctor just arrived last week.
That's wonderful.
Very well trained. Then we have a full separate cardiac ICU team. So the team, important is that you have OR covered with a great perfusionist, anesthesiologist, surgeons, come out to the post-operative care and cardiac ICU. If I go a little bit back behind, before surgery, you're looking at the neonatal team who's delivering the baby. We have a great neonatal team. Then you have a fetal cardiologist who's diagnosing this early during the pregnancy. And then before that, you can talk about OBGYN team, maternal team, who's screening it for us.
Okay.
So we have a comprehensive program from maternal, neonatal, fetal cardiologist, delivery team, then cardiac operating room with Dr. Massio and Dr. Chauhan, with anesthesia dedicated, perfusionist dedicated. Then you come to cardiac ICU after surgery. I have now 8 cardiac intensivists, 24/7 in the hospital.
Wow.
And we are available, of course, coming right away if something happens. But there's an in-house, in fact, 2 intensivists now in the Children's Hospital, one from pediatric ICU, regular ICU, and one for cardiac ICU.
So you've got all bases covered,
All
and it's
bases
all under one roof.
Yes. My belief is, and our team belief is, that you cannot run a good program if you don't have a 24/7 rescue team who can, because things will happen.
Oh yeah,
When
you
do
don't know
high
when.
tech, it's a high stake stuff. We are doing high risk deliveries, high risk babies, high risk patients are coming. We got to have a 24/7 strong team to rescue that complication, because complication will happen. We know that.
Yeah.
How do we rescue them?
Yeah.
Right? So we have that inbuilt process. We have ECMO, which is a heart-lung machine team, which is available 24/7. We can put patients, when they go in trouble, we can put patients within 20 minutes on a ECMO, which is the extracorporeal membrane oxygenation machine. And that's a life-saving. It's a life-saving.
Big deal.
And our outcome's been amazing. Dr. Frank Casey is our ECMO director within Heart Center, runs the program very well with help with the Dr. Hienga from the adult ECMO team. They work very closely. We have meetings together. We look at outcomes together.
Yeah.
As you probably heard that both pediatric and adult team has been given platinum award from the ELSO, which is the international and national level organization for the ECMO. And pediatric team is right now evolving into a silver and then hopefully gold and then platinum. So things are moving really good.
Yeah.
Our outcomes are very good. Our data is very transparent with the Society of Thoracic Surgery, which is STS data. So it's available, and our results are as good as any other great program in US or abroad.
So bottom line is, you don't have to leave the state to get top-notch care here.
Absolutely.
It's right here in our backyard, front yard.
I can easily say this for many specialties, pediatric, especially my cardiac world, of course. We have all covered. The things we don't do now is pediatric cardiac transplants, which we have plans to start. Hopefully planning is in place that within next 8 to 9 months, or absolutely within a year. So by this time next year, if I sit here, I'll be telling you more about pediatric cardiac transplants.
That's exciting. That's something to look forward to. So I always like to ask before we go, what's the most important thing you want our viewers or listeners to know about heart murmurs?
Most important thing is when you hear this, that my baby has a heart murmur, please remain calm. Look at the baby. It's the same baby you brought. Help is there. We're available. Honestly, our system should be mature enough that the community knows and pediatricians know that we try to see newborn babies same day or next day, and older kids, preferably same day, next day, but within 1 week. We have, and our numbers are everywhere. If you have a difficulty getting a patient to us, just say, give me heart center manager, give me chief of cardiology, give me that right person who can get you in. And we have slots open in the sense we keep for those reasons. We don't book them completely.
Okay.
And we have slots for the reason for different trainings and consultants on board. So please be calm. Yes, it will be looked at. It could be benign, could be pathologic or problematic, but baby's doing well. We have time. We have ways to fix it, repair it, and treat it. So my biggest message is that I know we worry as a parent, but our job is to say, let us worry, you be concerned so that you bring that to us and we can deal with this.
All right. Well, thank you so much for sharing all this information. I think you've put a lot of people at ease.
Absolutely.
Good to know.
That's the hope. And
there's a lot of solutions here available. No need to panic. But thank you for sharing all this today.
Absolutely. Thank you again for having me, and pleasure being here, and hopefully to see you more.
Okay, great. Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about heart murmurs and other children's conditions, visit WVUkids.com. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or the Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Udassi and everyone at WVU Medicine, thanks for joining us.